at around 2013. And the interesting thing is a lot of things have changed. We might do things a little bit differently. It was very much at the beginning of some of the treatment options that we did. So we'll take you through all those things, talk a little bit about how everything changed, what happened with this. And the reason why the case is so fascinating is because it's just a little bit different to the norm. There were a lot of things that we had to do a little differently. We also had a number of complications in this case, and the complications are some things we're still dealing with to this very day. And interestingly enough, we actually published a paper. This case was one of the cases that we published on the complications, and in the third series, we'll actually talk about those complications. So we're not going to spend hours. I don't want to sit here, and Mark and I don't want to sit for 2 hours, 3 hours talking about this. We're really going to spend just an hour and a little bit talking about the treatment planning part today. The second part within the next few days will be on the actual surgical treatment, and we hope that you join us for the surgical treatment. And then the final part, we're going to talk about the actual prosto, how Mark did the prosto, and how the whole thing, all the complications, how they manifested, and how we managed those complications, and what went wrong, what we felt went wrong, and how everything was done. I have to also at this point just give a huge shout out to MegaGen during these difficult times. Obviously, it's very difficult no one's earning anything, and MegaGen have helped us with the costing of hosting a much bigger group. So I just want a big shout out. This is MegaGen to MegaGen for everything they did, especially to Sean Matthews from MegaGen, who's absolutely brilliant and a great friend and a great friend of the academies. So thanks to MegaGen for that. So to take us forward, the first thing I want to do is obviously social media is important. It's important. I'd like you guys, if any of you guys are not part of our Facebook group, please join us on the Implant Academy. There's so much videos, so many cases which kind of complement exactly what we're saying here. So come on board, join us at the Academy, join us on Instagram, and also go to our website if there's anything more that you want to do. We'll be doing our online courses are coming shortly, which we're working very, very hard during the shutdown to get online. So that kind of stuff is coming through. So enough of the advertising bullshit. Let's get straight into the treatment and stuff like that. So essentially, this patient started treatment in around 2010. And what happened is that we saw the patient in 2012. The orthodontist referred the patient for an opinion because they had an infection. So what happened is he was having orthodontics, and the patient had been in orthodontics for almost 19 months. And during that 19 months, he developed this infection around the front teeth. And the reason why he was in orthodontics was because he had a hockey accident. We'll talk about that. So he had an anterior open bite. They were trying to fix it, but they had now hit a snag because the teeth were ankylosed and he had developed an infection. And the orthodontist referred the case to me now for the opinion about the infection and what was possible in the whole regard with regards to that. So when the patient came to me, his concern was one thing and one thing only. I want to have a nice smile. I want the beautiful on my smile. I want the beauty of my smile again. I want to have something back. And that was really his main complaint. And I think it's so important that we really understand and listen to the main complaint, because often we get so stuck in doing everything else that we forget what the patient's main complaint is, and we start doing other things which sometimes are more important, but often without either discussing the main complaint and the other issues, or at least making sure we understand what's going on, or the patient knows what's going on. We cannot really go forward. So his treatment history: he had an ice hockey accident in 2010, and he had 3 teeth were basically avulsed. In 2010, he also had endodontics of the 3 anteriors, the 1-2, the 1-1, and the 2-1, and subsequent infection of the 1-1. He had an apicectomy done on the 1-1 in 2010. He then started orthodontics in 2012, and at the end of 2013 came to see us with the complaint now and referral, because he really didn't know that there was an infection. So just to take, yeah, Mark, carry on.
I've just got a feeling that we're not on the same view that you're on. We're still on the first slide. So I don't know if you can advance that for us. I'm thinking that we need to be a little bit further forwards.
Are you seeing that?
No, we're only seeing the introductory slide of the multidisciplinary surgical and prosthetic management on an aesthetic case.
Let me just go out and go back in again.
Yeah. Okay. Sorry about that. I thought.
No, that's fine. Thank you for telling me.
No, that's fine. I mean, we didn't really miss anything, to be honest with you. I mean, it was a beautiful introduction, by the way.
Thank you very much.
That's all right.
All right. Are we on the same page now? Are we on main complaint now?
No, we're still just on the multidisciplinary, the initial slide, the kind of welcome slide, if you want to call it.
I'm not sure why this is not doing this again. I'm just going to close Facebook and I'm going to just quickly open it again. Sorry guys, I'm just going to quickly just shut down. We've got a small technical problem. So I'm just going to open up Keynote again and see if we can go in. Maybe there's an issue. Okay. Share screen. All right, let's share the screen. Okay, let's try that again. Let's see how we're going from there. All right, just tell me if that's going forward now.
Yeah, perfect.
Okay. Okay, so there we've got the main complaint.
Yeah.
Okay, so I'm just going to go through these quickly because this is what we spoke about. Sorry, guys. Technical issues. So basically, at this point, at 2012, this is when he came to see us with no real pain. There was no real problem. He had chronic infections around those front teeth, and as a result of that, he was now referred to us for this treatment. So when we looked at what was happening here, and we looked at the treatment workflow of how we're actually going to deal with this case, basically, we wanted to look at the diagnosis and the main complaint and the full mouth assessment. So that's the first thing that we're going to look at. And as I said in the previous thing, the critical issue here is that we understand what his main complaint is and we make sure that we are treating his main complaint, because without that, this is more often where we start to end up with litigation things where we don't really take into account what's necessary. The next thing that we did is we did a comprehensive and full mouth treatment of active disease. So in other words, we eliminated all active disease. So that's the key factor. And one of the most important things that one has to do is to make sure that we eliminate all of the active disease in the mouth. So that's the first thing that we did. But in this case, which might be a little bit different, because you'll understand that he came for one very, very specific purpose, and that was for the anterior aesthetics. And because of the fact that there wasn't any other disease, which we'll go through soon, we kind of went a little bit differently to the way one would normally do with perio assessment, etc. And it's really, so we looked at everything, we looked at the mouth, we looked at the whole workflow, and then we did our initial treatment planning and discussion with the patient. And it's important here because if we don't do our initial treatment plan and discussion at this point in time, what happens often with the patients is that they start to get lost in what is actually necessary. And especially when one starts talking about aesthetics, because often and especially from a surgical point of view, being a person who's a surgeon, etc., it is very, very difficult to assess the whole case without the aesthetics. And I'm going to ask Mark just to come in here, because the next phase that we went through was aesthetic diagnosis. And Mark, just explain why we went to the aesthetic diagnosis at this point.
Okay. Yeah. So I think that at this point, can you hear me? Can you hear me, Howie?
Yes, I can hear you perfectly.
Okay. So one of the interesting things about, if we take it back even a little bit further, is that, in the restorative element of dentistry, we understood that when we were treatment planning cases, that we needed to use the face to drive the treatment. We needed to, in other words, and it was a common phenomenon at this stage, to do facially driven treatment. And that started really even a decade or more than a decade before that. And I think that what happened often in implant dentistry is that because it was a team, the team didn't necessarily get involved at the right time. So in other words, members of that team were introduced, not at the beginning, but when it was anticipated that the restorative phase was going to be necessary. And in this case particularly, a lot of very important decisions had to be made initially because they were going to most likely have either a positive or a negative impact on the aesthetic outcome. And let's remember what the main complaint was, or the wish of the patient was to give him back his smile. So it's super important to understand the sequencing of making decisions, that aesthetic outcomes need to be thought at the right time. And so this is why at this point we needed to understand what was the final aesthetic outcome, or what was our goal, and then go back and really look at how we were going to achieve that. So, once we had decided, in this case, maybe which teeth needed to go, we had to then look at the aesthetic demands of the case and then start to put the nitty-gritty of the treatment plan into process. Does that make sense?
100%. And I think the key factor here is, this is why at this point in time, before I even started with the surgical planning, my initial treatment discussion with the patient was around the fact of what was going on with the infection. And we're going to get to the x-rays and the clinical examination soon. Once we had all those factors under our belt, the first thing I did was I said, right, now I want you to see my colleague who's going to take over the later parts of treatment, but explaining to him how important that part was to my initial treatment, because I needed all that information well before I started any of my surgical treatment. And you'll understand a little bit more of it as we get into the treatment planning of this case. So I think the key factor here is that, and what one can say is that when you are working in a team, it's key that the whole team gets involved in the case. And certainly, if you're not a smile design expert, or you don't understand aesthetics properly, it's something that is important to learn. It's because these things it's not possible to do these kind of cases and get the kind of consistent results. And I think that's the key factor here, Mark, if you would agree, is consistency and predictability. Because often we hit it, it's either right or wrong. And more often, if it's wrong, it's because the technician didn't do the job correctly and they didn't get the lines right, etc. But it's not really their job. It's our job.
I just think, there's two things. There wasn't enough information for a member of the team. In other words, he wasn't guided by maybe the aesthetic outcome. Or the planning was just poor. That's generally what happens, or there is no planning. There's not enough planning. So I think the key to this case and all the cases, is meticulous planning. If the planning is in place, then most likely, yes, there are going to be hiccups in the treatment, but most likely the outcome is going to be desirable, for the patient and the team. Yeah.
So once Mark and I have had a meeting, we've discussed, we've done the aesthetic diagnosis, and this is all done pretty much within a week. So we're not waiting months and years for us to do this. We're pretty much getting this done pretty fast. And I think that's the fantastic thing about the internet and sharing and drop boxes and WeTransfers and all the new technology that we have, or even TeamViewer, where I can go and take control of Mark's computer at his place and have a look at what we're doing, which we do so often with our technicians, and get shapes right, sizes right, and things like that. We have that meeting. Once that meeting is done, we then sit with the patient, and now we have another comprehensive treatment plan, because it's only really at this point in time that we can start giving the patient true costing of treatment, giving the patient all the possible treatment options, because now it's only now that we understand from an aesthetic point of view we understand from a pathological point of view, we understand from an infective point of view, what does this patient require? And until such time as we have that, we cannot give an estimation. We cannot give a full treatment plan. We cannot give anything until we've got all of that under the belt. Luckily enough, with all the modern technologies, I said that these things are things that are very easy to do. And Mark will talk a little bit more about the aesthetic side of treatment planning a little bit later. So at this point is where we sit down and we have it. And often this appointment session for me, and I don't know about you, Mark, but we do this for free. It's something that the patient comes down, we sit them at the end of the day, and we go through all the different options, and you'll see that there's pretty much 6 different treatment options that we came up with for the guy, and we explained all the different options to them. And I think one of the key factors when explaining these options is also explaining complications, which we'll talk about a little bit more.
Yeah.
So,
I mean, just to butt in there, Howie, I think that what's super important, you know, is always that the patient understands the treatment, and we understand the treatment. So if there are any areas that we might have to compromise on the aesthetics because of whatever, we're explaining to the patient before we start the treatment, rather than at the end and trying to not make excuses, but try to justify to the patient why something didn't look exactly or didn't work out exactly as we wanted. So I think the planning will always allow us to see the complications coming up ahead.
Yeah. Well, I think there's one thing for those who've always been at the academy, there's one adage that I always use. It's information versus explanation. And one of my professors at university always taught me that you must give every possible complication and also explain to the patient how you're going to manage the complication right from the start. Some people say, yes, but it scares my patient away. But I think with Basil Mizrahi the other day, the one thing he said is you want to have patients that are your friends. You want to have patients that are actually be there. And I think when the patient gets scared because of potential complications, those are not the patients you want to treat. But the thing is it's also how you discuss complication. Because if you go there and say, this is the potential for complication, but the complication might not happen. But if the complication does happen, this is how I'm going to manage it. And this is what I'm going to do. So before they even start, it is already done. It's out of the question. You've got everything nailed. And I think that's one of the keys I have to tell you for me being able to sleep better at night, because more often than not, I speak to guys who phone me and they're like, oh my God, I've got this complication. The patient's upset. You know what I mean? I can't sleep now for 3 weeks. I've been upset. I mean, how many times has that happened to you, Mark? I know me hundreds of times. But the minute I took that away and I spoke about complication and I gave the patient all the information that was necessary about all potential pitfalls and how I was going to manage them, because that was the key. How do I manage those complications? Then when it happened, there was no luck. You know what I mean? I now have to go and tell the patient, it's like, this is what's happened. Complication 1F is what we discussed and what you've got in your informed consent, etc. And this is how we're going to manage it. And they're like, okay, you know, there's a lot more acceptance from the patients, and I think that's key. You agree with that?
Perfect.
Okay. All right. So once we've done that, we can then start with our surgical treatment. Once our surgical treatment, barring complications, we carry on with our final prosthetic treatment. And that's normally the normal workflow. But we have to add one thing in here that's really left out, and it is a bugbear of both Mark and I, and that is the maintenance program. Because most people, and I also give a shout out to specialists, because I always ask specialists, how many times do you actually follow your cases up? How many times do you, if you, the surgeon who's actually placed the implant, do you refer the patient away and then say, okay, well, I'll wash my hands, I don't need to look at it unless there's a complication? And I never ever do that. I know some dentists get a little irritated with me, but I bring my patients back 1 month, I bring them back 3 months after the restorative work has been done. I make sure there's no cement under the gums. I take x-rays, I check the bone levels, and I try and bring my patients back on a yearly basis. Obviously, if they are doing general dentistry and they're seeing general dentistry, and Mark, I think you can chip in now how your maintenance program goes from a generalist point of view more than a specialist. But from a specialist point of view, I want to see my patients every year. Mark?
Yeah. Yeah, listen, what we've started doing is we've started actually implementing what we call a maintenance, a service plan, like you would when you buy an expensive car. And as we're getting patients to sign the service plan so that they understand the commitment to this process going forwards. That, and I never tell them that the treatment is finished. I say we've finished, we've got to the point where we've completed the treatment. We're now moving to the next phase, which is maintenance. So they never think that it's over or that it's ended. You know, so I think that's also a key element, how the patient, and then, yeah, it's the service plan, and each one will be different. So, you know, obviously that will involve, in a restorative point of view, wearing a night guard. They have to sign that they're going to do it. They're going to come for their hygiene visits. They're going to come to see me once a year, in order that I service the maintenance of their case going forward. So, yeah, it's a great way, to be honest with you, because the patients can see that I really care about them.
Yeah. I think the other issue with that also, Mark, is that also, you know, often we because we neglect this part, and I give my patients also, I wouldn't call it a maintenance plan, but certainly a way forward, a plan, and why, a kind of a form that explains why we want to bring them back, what the purpose is, what we're going to do, what the charges are going to be, etc. There are all those things that come into it. And what happens is we also categorically state at the bottom, if you do not follow this plan, which is pretty much like any warranty you get from a car, please, we cannot be held responsible if you don't follow our maintenance program.
100%.
Are you not seeing the hygienist? Then they come back 3 years later, oh, I'm losing bone, it's your fault. And it's like, well, did you follow our plan? If you were here 6 months after, we could have checked. Now there's cement under the gum, blah, 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 all these sort of things. You didn't follow the plan. How we cannot take responsibility. And when the patient sees that, and I had exactly this kind of case the other day where the patient came back 18 months later, cement under the gum, bone loss. Now he's upset. And I said, well, did you read the plan? You know, he knows he's upset that he didn't follow it. He didn't think, he wasn't feeling anything, didn't think it was necessary. Now he's sorry. So now it was vestibuloplasty that he needed to go through. He needed to go through decontamination. So it's cool. I earn more money. It's a wonderful way to do dentistry. But the thing is, it took all the stress off me because I didn't have to worry about that sort of thing. All right. So if we go into the clinical examination, so this is pretty much how the patient presented, and we're going to look intraorally. Obviously, we've done an extraoral examination as well. We've palpated everything. We've looked at the soft tissue. We looked at we check for any growths, any nodules, etc. That's the standard protocol for every patient that we have. TM joint assessment, any growths around the face, etc., etc. Salivary gland function, salivary gland growth, swellings, etc. Under the tongue, all that kind of stuff is absolutely key. And then we go to the more specific stuff around what this patient looked like, was having. And if you notice on the top there, we've got the 1-1 and the 1-2. Both of those teeth were ankylosed, and this is the information we got from the orthodontist because he had been trying to move those teeth for the last 19 months and was having no success with that. Generally, the patient was periodontally stable. Obviously, there was some gingivitis associated with the bracketing and the orthodontics, which is nothing unusual. There was certainly there was pocketing around the 1-1, so we could probe buccal, palatal, and there was suppuration. So there was active infection coming from the 1-1, and there was pocketing around the palatal portion of the 1-2, but there was no suppuration coming from that side. So there was just a slightly deeper pocket of around 5 to 6 millimeters around the palatal portion of the 2. Marco, there was something you wanted to mention here?
Yeah, I just want to say that obviously the orthodontics actually had almost been completed. He had actually quite a severe anterior open bite. I don't think that's going to have too much to play with the eventual outcome, but it was unfortunate that he couldn't get to the end of the orthodontic process. We had, basically had to make decisions about aborting this part of the treatment because of what you've already highlighted, the ankylosed teeth and the infection. And I think also, well, we'll go on to the radiographic elements in a minute, but yeah, that would have been a key process. Had this been done periodically during the orthodontic treatment, I think it would have highlighted a lot of other problems that had arisen a long time ago. So
Yeah.
So again, it's about teamwork. You know, it's unfortunate that this patient maybe didn't come for a kind of aesthetic restorative consultation maybe 6 months prior to this. So that would be my only input. I don't think there was a team in place at the right time addressing all the issues. To be honest with you, we were called in maybe a little bit too late.
Yeah, there's no doubt. There's no doubt. And I think once you get to actually see the X-rays, you'll get a real good feel for where this was and how things had kind of really gone pear-shaped and why the patient was in so much trouble now. So if we look at the radiographic examination, you can kind of see from the top there, you can see we had external root resorption, we had apical infection, bone destruction around the 1-1. You can see not moving at all. If we have a look as well, from the on this tooth over here, on the 1-2, we had external resorption, we had apical resorption, we also had apical infection. If we look at the 2-1, you can see a massive fenestration in that area, which really was there was a massive amount of bone destruction there and things that were going on. So from having a look at this, you can kind of almost see that all these things, so for the last 19 months, they were having orthodontics, but no one was looking at the teeth. And as a result of that, we know that when you're moving orthodontic teeth at the same time as having all this pathology, it actually accelerates the bone destruction. So if we carry on with this and we move on, you can see here. So this is the 1-2. And here you can see that there's external root resorption on the palatal side, there's apical root resorption, and there's also apical infection around the tip. So the endodontics that was done a couple of years before has not been successful. As a result, you can see also if one has a look, and I'm just going to highlight this area here. If one has a look at this area here, you can actually see what the bone looks like here and how the bone is actually starting to penetrate into the deeper portion of the bone and how that infection is actually starting to destroy the bone in that area. So not a very good look for the 1-2, and the tooth looking a little bit terminal for us. We look at the 1-1, and here you can see the massive damage. I mean, there's literally absolutely nothing left of this tooth. We've got the previous apicectomy. The amalgam all looks like it's sitting outside the root rather than inside the root. Possible root resorption that's taken place there. You can see the root resorption on the distal side, and you can see the bone destruction around this tooth, which is extensive. So the minute we start to see this kind of thing, one starts to understand now that for me to grow bone here, I'm now going to take a huge amount of time. So this is now going to be a case where it's going to take me, if I'm going to use autogenous bone, I've got to extract the tooth. I've got to wait for everything to heal. Then I'm going to do bone grafting. So we're going to talk about that later. But you can understand now by getting a view of what the center looked like, how dire the situation was for this patient. And this was the contentious tooth, and I think this is where Mark and I struggled the most as to what we were going to do here, and I think this is where a lot of debate can be had, if you would agree with that, Mark, around how this should have been managed and the way we managed it. And I don't think that we did that. Our treatment is right, and I think there's lots of different options, and we'll go into that a little bit later, and you can discuss that. But you can see clearly, firstly, the buccal fenestration. The buccal fenestration is clear in this area over here. You can see the massive apical infection that's taking place. You can see a little bit of buccal fenestration over there. So a very large buccal fenestration that we can see. We've got really great bone at the apex though. If we look at the remaining bone around the top there, everything there, we've got good bone on the buccal, good thick bone here, almost 1 millimeter thick, which is not a normal type of situation for that. So it's really a good place for us to work. And moving on, let's have a look now. So I think with that in mind, let's have a look now at the different treatment options. And obviously, the first thing that one always thinks about is do nothing. But I think we're all in agreement here. We're not even putting that up as a treatment plan, because do nothing is not an option. There is active infection here. But Mark, if I can ask you about what do you think about the option of a 3-unit bridge with socket preservation in this area?
Okay, so the first thing I'd just like to add, and I think we just have to remind everyone who's listening and ourselves that this case goes back to 2013. So, you know, first of all, I'm lucky to work with an endodontist in my practice. And it's interesting because the standard of care of endodontics is, first of all, 3D x-rays. You know, we don't use 2D x-rays anymore on diagnosis. But the key is also follow-up x-rays. You know, we take 3D x-rays follow-up to check healing. And so, you know, that definitely would have changed, you know, from 2013 to now. But, you know, I think a 3-unit bridge here is out of the question, because obviously the 1-2 has resorption. And so, you know, there's no predictable way of treating the resorption. And so, and as abutment tooth going through the long term, this is not an option, you know. And I think one has to also look at the 2-1 and understand the history of these 3 teeth, that the 1-1 and the 1-2 have ended up with resorption. So I'm not saying that it would definitely be something that would happen to the 2-1, but it's something that we have to take into account, given those other two cases of resorption, that if we're hinging a long-term solution for this patient on this tooth, it's not looking good. And also there was quite a lot of coronal destruction through a fairly excessive access chamber that had been provided for the endodontics. So I'm not sure that there was a lot of coronal tooth structure on that would have been viable as an abutment in the long term. So that's my feeling. But obviously, first of all, you can't even think about a 3-unit bridge until you've controlled all the infection. So.
Yeah. So, I mean, to have done that, we would have had to then either do re-endo apicectomies, and then obviously the problem is we still had all the external resorption on the 1-2. So how would we have managed that? So any 3-unit bridge really would have been a short-term and maximum lucky mid-range option. Would you agree with that?
Sure, and obviously as it goes forwards with the resorption, there's the continued risk of more infection and more bone destruction. So you have to weigh up those consequences as well, given that when that eventually fails, you're going to be in the deeper end than you were right now. So, you know, I think that's also something that you have to take into account. You know, is when it fails, what are we going to be left with?
Yeah. And I think the key factor here is, I think in 2013, I mean, he's a very young guy. Also, I think he was in his 20s or late 20s at the time when this happened. And I mean, you know, if he's in his late 20s, we're looking at 70 plus years worth of treatment that we are looking to try and maintain, barring a little bit of chipping of porcelain or something like that. But ultimately to maintain implants and stuff like that, and to maintain bone over that time, I think that's the crux, is how are we going to manage that over the 70 plus years that our treatment hopefully will last. Okay, so we move on to the second treatment plan option, and the second treatment plan option now comes down to the possibility of re-endo. The endo on both, interestingly enough, is pretty good, Mark. I think you would agree from the CBCTs, both endos were done pretty well. Could one redo the endos? I think endodontists would obviously say, yes, if I did it, we could redo it. But I think the endodontics was pretty good. It was solid. It was to the apex. There was no issues from that we could see. So the next thing comes down to, can we do apicectomies? You know, obviously apicectomy requires a good endo. You know what I mean? It needs a good endo to be done. That's number one. It needs a long enough root that we can cut off at least 3 millimeters of the apex. It needs another 3 millimeters from that point, so that we can then seal with some sort of retrograde sealant from the apex upwards. And yes, definitely apicectomies here are definitely options. But I suppose the apicectomy on the 1-2, though, does not take care of the resorption. So again, by doing an apicectomy on the 1-2, we have a problem. Is it going to give us that kind of success? And I think from a long-term point of view, definitely not. The apicectomy on the other tooth, on the 1-1, again, is something the 2-1, that's certainly something that can be done. But the problem there now is that we also, and I think it's something which we'll talk about just now, is what the patient's needs were, and we'll talk about them in a sec. But let's just talk about here. If I'm doing an apicectomy, I certainly do not want to do an apicectomy and GBR at the same time. Because if I do an apicectomy, I need to know that I'm going to get proper healing of that apical area before I start doing any kind of buccal GBR, never mind the fact that in this case I have to do vertical GBR to fix up, which is the most difficult type of guided bone regeneration we have. So if you think about that, so what it then means is I then have to do the apicectomy of the tooth. I've got to leave it for at least 6 months to assess the healing of the apex. Hopefully it heals completely. Sometimes it heals with a little bit of scarring, etc. And then I'm not sure, although when we open it the second time, we'll be able to assess the type of tissue that we've got there, whether it's thick fibrous tissue versus granulomatous tissue. So that's something we're able to assess. But it does delay the GBR because we definitely need to get everything done first. We have to get the apicectomies done first. We have to get everything to heal first before we sort everything out, before we start with our bone grafting. And then again, on the 1-2, apicectomy does not again deal with the external resorption. So obviously we then have the options of possibly apicectomy, again socket preservation, and socket shield extraction. People obviously ask, well, can you do a socket shield extraction where there's apical infection? And the answer is definitively yes. And Jonathan and myself did a publication in the Dentistry SA, and Jonathan will also just add for one of these publications, we will put a link to the publications in the chat or in the Q&A section that you can download immediately. There are 2 papers. The one is done by ourselves, which we did in 2015, Jonathan and myself, and there's a recent paper by Joseph Kahn, and everybody knows Joseph Kahn, probably one of the best clinicians and researchers in the world. And Joseph Kahn also did a recent publication in an International Journal of Aesthetic Dentistry where they did an apicectomy with apical GBR, with infection, etc., and with unbelievable outcomes. And certainly placing implants. Can we just switch off our audio? Can we just switch off our audio for people there who have? We can. Jonathan. Jonathan, can we just switch off that audio? Thanks.
It's a bit difficult to find who joined now with the audio, but if everyone who's joining can please make sure their video and audio is off, thank you. I'll find out who that offender was in a second.
Yeah, you get him, Jonathan. All right, so treatment plan 3 now comes down to a socket shield on the lateral, and obviously socket preservation on the central, and obviously then apicectomy on the apicectomy of the 2-1. So this is another possible treatment, and let's discuss this. As I said, the socket shield with apical infection is definitely a possibility. It's something that we can do. There was good apical bone that could give us good primary stability of an implant. There's 2 issues with the cantilever bridge, though, that I have, and Mark, maybe you can step in at this point as well, is that from a surgical point of view, when I'm doing a socket shield on the lateral, it means that my implant's going to be quite narrow. I can't use a very wide implant there. So with the cantilever coming off there, the amount of cantilever forces on a narrow diameter implant, even though hopefully we're using a Morse taper connection, which is certainly my preference, one's going to get less micromotion, less movement. But what are your feelings about a cantilever off a narrow diameter? Can one control the forces? What are your feelings there?
I think that certainly from sort of an occlusal point of view, in a case like this, one can manage that in a predictable way. So I wouldn't be overly concerned. However, that is deemed to be a kind of not a compromised treatment, but it's not an ideal treatment outcome for the patient, having to cantilever in this situation. And I think also, one has to understand where soft tissue and everything needs to go, which will be we'll have a look at later on. But yeah, it's definitely a possibility. There's no question that is. But again, it's the number of surgeries.
It's a compromise. Would you agree with that?
It's a compromised treatment. I would have thought, but it's certainly a possibility. And again, if the patient feels this is where they want to go, then that's an option. So it's certainly an option.
Yeah. Okay. So let's carry on and go on onto the fourth one. And the fourth one is really now kind of trying to put the implant in the central. And here, the reason I say from a surgical point of view is I can put a wider diameter implant in the central. I think with protrusive movements, one's got more control if you can have your protrusive movement on the implant and then control your occlusion on the lateral almost completely by taking the lateral out of the occlusion, because it doesn't take much force. So a cantilever distal is always better than a cantilever anterior. There's no doubt about it, with a wider diameter implant, which will give us a better option. The possibility now of a pontic shield now. So if we're going to do extracting both the 1-1 and the 1-2, which is what we're going to do here, because of the root resorption, we cannot do a root submergence on a tooth that has apical infection. So for those of you who understand about partial extraction therapy is where we remove part of the tooth and not take out all of the tooth, leaving the good, taking away the bad, which is a saying that comes from Chuck Schumer, a very good perio that I work with in the States. And basically, pontic shield is where we're combining a socket shield with a root submergence. And this is a technique that Jonathan, myself, and Maurice Salama published, I think in 2016 or 2017. And again, we'll put a link to that in the chat and in the thing, you'll be able to download that article as well as all the other articles on partial extraction therapy, just to give you an understanding of what we're dealing with there. If we're going to do a pontic shield, what we're going to do is we're going to do a socket shield. We're then going to fill it with bone graft material. We're then going to do what's called a rotated palatal flap, which is a vascularized flap. Some people from the US, they call it a vascularized interpositional connective tissue graft, which is the same thing, but described in a different way. So it's basically a pedicle flap that's rotated from the palate to close up a pontic shield. And this is essential, either closing with some kind of rotated flap or closing with a free gingival graft is absolutely essential to make sure that you get closure. If you just put bone in and PRF or something or some kind of collagen plug and expect closure, it's not going to close, it's going to stay open. And that we showed categorically in our case series that we published in the International Journal of Perio Restorative. So this is another thing. And then obviously what would happen is we would again need to do all of this work first, extract the central, extract the 2-1, do the pontic shield, do the apicectomy, allow that to heal, make sure everything's solid and healthy. And only at that stage, now 4 to 6 months later, we can then come back and we can do our GBR. Then 4 months after that, or 8 months or 9 months, depending on the type of GBR that you're going to do. And we can talk about that in the treatment section. Then we would come back and do the implant and then only come and do the crown. So it does produce a much more lengthy treatment option for the patient and really extends our treatment plan extensively. All right, so the other option is to place 2 implants in the area. Obviously, with the patients with a fairly high lip line, placing 2 implants is not great. But with socket shield extraction, we do know that adjacent implants, we can maintain the papilla to some degree, not 100%, but we certainly get a much better maintenance of papilla, so it can be done. But again, the fact that we've got such a large GBR, I think treatment plan 5, in my opinion, I'd rather go for the cantilever than having to go through the whole GBR and doing this. I don't know if you would agree with that, Mark.
Yeah, I totally agree with that. I think managing it also from a prosthetic point of view, two implants together, I can tell you that that's going to be very lucky to get a really good aesthetic outcome. You know, so I think the compromise there will be the aesthetics.
Yeah,
there's no question.
Well, I think it'll be interesting. We are working now on a paper on adjacent implants with socket shield, and you and I have done a few, and we've got some great results in that regard. But we're not dealing with two socket shields next to each other. We're dealing with a socket shield next to a massive GBR, and the minute we raise flaps here, we are going to lose that papilla. There's no doubt about it. So that's where the issue comes. All right. So coming into the last possible treatment option is the socket shield extraction of two teeth, socket preservation in the central. What are the benefits and the negatives of this? The benefits of this is that it means we don't have to do long guided bone regeneration treatment options. It means we don't have to worry about infection. So we are taking care of all the infection in one go. So that, because if I'm going to do an apicectomy, if I'm going to do any work on the adjacents, I don't want to pack any bone into that socket until such time as I know that the adjacent infection is gone, because the risk of getting infection, and we're going to see what happens in the complications later anyway, the risk is high. So the benefit of this treatment is that we are going to shorten and reduce the treatment time dramatically. And I think, Mark, you'd agree that this case, doing it this way, we could finish within 2 to 3 months. The whole case could be finished and into finals. The negative of this case is that there's possibly a tooth in the 2-1 area that we are sacrificing, that would mean that he basically takes out a tooth that we could salvage. And I think the 2-1 definitely could be salvaged, and I think a lot of people would agree with that. So that's the negative part of that. So basically, these are the 6 treatment plan options that we gave to the patient. And I think at this point in time, what I'm going to do is I'm going to open a poll, and I'd like you all to go to your polls in the bottom and just give us an idea on what your thoughts are. Where would you go? And we're going to give you a few minutes just to go through this and see how many people vote, and then we'll see what the results are. So let's get as many as you can to vote. That'd be great. If you can't find it, it's on the little toolbar at the bottom. You'll find where it says poll, P-O-L-L. It's there.
Okay, Howard.
What's the thing? Yeah.
The poll should be coming up automatically for everyone. So maybe, because there's a lot of reading and they're quite lengthy, each option, maybe you just want to work through each option one by one.
Okay, so basically, thanks, Jonathan. So basically what we've done here is we've got treatment plan 1, which is the extraction of the 1-1 with a 3-unit bridge. So far, we're on 0. The second, so it's basically exactly as I've described in the treatment plans: extract 1-1, GBR and single implant, with an apicectomy of 1-1, apicectomy of the 1-2 and 2-1. Treatment plan 3 is extraction of the 1-1, socket preservation, socket shield extraction 1-2, cantilever from the 1-2 to the 1-1 apicectomy. I think I'm reading too much into it. I think everybody can. I think it's pretty clear to read on there. I think what's important here, and something that might help understand the way we went for treatment, is that when we started discussing with this patient, Mark, and I think you were very much part of that, when we started discussing treatment options for the patient, and we started to explain bone grafting techniques, and we started explaining what actually went into the GBR, because we had, and I think anyone who understands bone grafting knows that the technique itself, vertical grafting, number one, is difficult. And there are 2 potential techniques here. One is either using autogenous bone, which is the fastest, which in my hands, and others might be different, but I'm certainly talking my experience and the way I do it, would take me at least 7 months before we could put a crown on that implant. So it's 4 months, it's 2 months, sorry, even longer, 8 to 9 months. So it's 2 months extraction, waiting for the infections of the adjacent teeth to heal. Then placing implant, then placing bone. If I'm using autogenous bone, it's going to take around 4 months. If I'm using some sort of synthetic bone, okay, then I'm going to need some sort of titanium reinforced membranes, titanium meshes, because normal resorbable membranes doesn't hack it. And that in itself is going to take anywhere up to 9 months of bone healing before we can even put the implant in. And then another 3 to 4 months for that implant to integrate, et cetera, et cetera. So it increases the treatment time. So in that discussion, once we started having that discussion with the patient, there was no doubt that the patient was pretty much like, I'm not so sure that that bone grafting is the way he wants to go. All right, so let's go to the poll now. 69 out of 158 have voted, so that's 43. Okay, 71, 72, 73. Okay, so people are taking their time. I'll just go through. Let's give it a few
Can I just say one thing as well about that? You know, that also in the can you hear me? So
yeah, go.
Also in the treatment discussion with the patient, I think it was important that we talked about predictability of the aesthetic outcome. You know, in other words, you know, where did we feel that we were going to have the most control in the best aesthetic outcome? You know, I think that's also relevant, not just to the amount of surgeries, you know, that he was really driven by how it was going to look, you know, and that was a key element. And so we had to also question ourselves where we felt the most comfortable in achieving the best aesthetic outcome. I think that also guided us in a way as to making a decision, the decision we made for the patient.
Yeah, I think that's such a critical view, and again, it comes down to the minute we start raising flaps here, the papillae are going to disappear to some degree, if not fully, and we're going to end up with having to put some stuff there. So I'm going to end the poll now, and we can just share the results with everybody. And we can kind of get a good view here. It's quite a wide spread of what we think. 3% felt that a 3-unit bridge. 10% felt some apicectomies, extraction of the 1-1, apicectomy of the 1-2 and the 2-1. 11% felt about the cantilever with socket shield from the 1-2 with socket preservation. 18% felt implant with GBI in the 1-1 with shields, rotated pallet for flaps of the 2-1 and cantilever bridge. 21% extraction of the 1-1 GBR of the 1-1 side socket shield extraction, 1-2 and 2-1 apicectomy, individual crowns for all teeth. And treatment plan 6 extraction, which was most of the people, were 36% for the last treatment. I just want to reiterate, and I think Mark, you would agree here, that there's no right or wrong.
No,
and
no right or wrong.
certainly there's lots of different possibilities and options for each patient. And as I say, we'll talk about it because we're going to deal with it how we dealt with it in the next series. Yeah. So we'll go into that next. But what I want to share with you now, okay, there's just the treatment plan poll. Sorry, I should have showed this, Jonathan. I forgot the slide was here. There you can see the different options. Okay, that was the poll. So we see there 36% for the last one was the most favored. Okay, so if we have a look at this, and this is another thing that we have to discuss, because this is really an issue where the surgeons really are at fault with this type of situation, where more often than not, when we get the case and we haven't done any aesthetic diagnosis, and I'm one of those as well, so I have to take responsibility. And certainly until DSD came along, it was the way we were doing things, and until it was changed by Christian Coachman and the way we really looked at facially driven stuff, this is what we looked at. And from there, I would look at the whole situation. I'd say, right, my gingival levels of my laterals look good with my canines. I've maybe lost a little bit of gingival recession on my 1-1. Maybe I could do some soft tissue grafting to bulk that out when I extract that tooth, etc., or with bone grafting, depending what we're going to do. But if I look at the 1-1, the 2-1, the gingiva actually doesn't look like it's in a bad position for me. Certainly the incisal edges are a little bit short, and those can be important. But this is really where we stopped. And I think, Mark, this is really what you've been alluding to, where the biggest problem comes in, because I now, if I take it at this point in time and I start to now only do my treatment from an intraoral point of view, the risk of me putting my implants in the wrong position and not ending up with things in the right position are quite high. And that's why it's important that you work with somebody that understands the following concepts. And I'm going to hand it over to Mark and talk about what is success.
So, yeah, what is success really? I mean, success is, I think, is going to be judged by how our patients feel on the aesthetic outcome, certainly in a case like our patient that we're discussing. You know, I'm not sure that the patient is going to really judge us on how successful his bone graft was or any other factor. He's going to really look at the case. And, you know, he's not even going to really judge us on whether it took 6 months or 9 months. He's going to look at the final outcome. And then he's going to be critical about whether we were successful or not. And I think too often, unfortunately, a lot of decisions are based on teeth, not the face. You know, and so I have a saying, treat the face, not the tooth. You know, because this is the reality. Treat the patient, treat the face. And that's where the whole process starts, because this is a classic example, the case that we're looking at, where, you know, a lot of us in our profession might judge this as a successful implant case. But the reality, and I can tell you honestly from this patient, because I think we both know the patient, is that this patient came back to us because they were unhappy with the result. And they were unhappy with the result because of what they could see. And the reality here is that, you know, if the implants are in the wrong place, what happens is everything from there goes in the wrong direction. In other words, the crowns, because we need tooth form, need to be a certain proportion. So that means that the incisal edge is going to be in the wrong position. We're going to have long contacts maybe. And so all of these things are going to be negative when the patient evaluates the case, because the evaluation is how it looks, to be honest with you. So if we go on to the next slide, we'll see that we end up with a patient where there's no papilla, the tooth proportion is wrong, the pink aesthetics is a complete failure, the smile line is incorrect. And, you know, I think at this point it's worth mentioning, you know, the smile, or analyzing the smile in one photo. And we'll get to that maybe later when we talk about dynamic versus static. But, you know, the reality is, in a case like this, a lot of decisions were made at the beginning which had an impact, and negative decisions were made that had an impact, or maybe decisions weren't made at the beginning that had a negative impact on the outcome. Having said that, you know, I think in a lot of implant circles, this would deem to be a successful case. In other words, the implants had integrated, you know, the ceramic or the restorative fits nicely. You know, there's nothing wrong kind of from a health point of view, but how it looks is the key element. So that's the reason that we need to really plan these things meticulously, not from just a biological and a functional point of view, but also from an aesthetic point of view. So these things are so intertwined that one decision can't be made without the other, in my opinion. So, you know, it's the comprehensive way of looking at a case, you know, not just looking where the bone is, or looking, you know, where's the best place to place the implant, but it's looking at actually what is going to be the final outcome for the patient. And let's be honest, patients are critical about this stuff. They know a lot about how their teeth look. That I can tell you.
The internet is a wonderful thing. And I think, Mark, to go back there, I think it's very important for the generalists, if we can advise the generalists out there who are doing work with specialists who aren't either interested in the aesthetics or who are handing over the cases to you before an aesthetic diagnosis gets done. I think one has to really have a dialogue, a strong and a stern dialogue with the person, whether they're a specialist or a generalist. Whoever's placing the implants for you, they need to understand that that we always talk about crown down, but it's not crown down anymore, is it? It's actually face down. We're doing face down. We're doing face down dentistry. So we are working from the face to the mouth, to the teeth, to the implants, to the bone.
Yes.
And I think if we can kind of change that whole concept rather than just thinking, because the whole concept of crown down is great, but it's not, it doesn't really describe what we're doing, does it?
Not at all. No,
Okay.
100%. And to be honest with you, I mean, we'll go on to the analysis and how we do it. I mean, I think that there are a number of different ways. I mean, DSD is just one, be honest with you. I'm not going to say that it's the only way. There's a bunch of different ways. But the important thing is that there is a facial analysis and there are aesthetic or decisions made based on the final aesthetic outcome. That's the key thing.
Yeah.
How you do it is not what we're going to discuss. It's that it's done. You know, that's mandatory, I think. So when we do this, the whole process begins with the facial analysis, and this is regardless of what treatment we're going to offer the patient. We don't know yet.
Yeah.
The purpose of doing a facial analysis and a DSD or whatever you want to call it is to determine exactly what teeth need treatment from an aesthetic point of view. Yeah, we're going to look at that from a biological point of view as well, because I've had a number of cases where a patient has come in with one tooth that needs one implant crown. However, after a smile analysis or facial analysis and a design based on the face, we've ended up treating 4 teeth because that's what we needed to correct the smile, which is what the patient was requesting. If the patient refuses having 4 teeth, that's great, but at least we don't get to the end of the treatment and then the patient is disappointed with the outcome. That's the key thing about smile analysis, is that we understand all the smile problems before we start so we can address them. Because going back, what was the main complaint? Fix my smile. You know,
Absolutely.
And so that's why we go through. So if we look at smile analysis, and I'm not going to spend much time on this, but the reality is, you know, the first thing that changed a lot of things for me is I started taking photographs. I mean, I think that's a key thing still today. There's so many cases that are done without a single photograph. You know, if you don't take photographs, you can't do smile analysis, in my opinion. And so we have to start with a starting point, which is the natural head position. We look at the facial midline. So in other words, the natural head position is getting the head in a horizontal plane first, which is the horizontal line. Then we look at the facial. This is the order that we do it. Facial midline, then we look at the relationship between the facial midline and the dental midline. And then, you know, what's amazing that this was now seven years ago that we did this, and that we were doing this as a routine, which is really amazing. And how that's changed now and how we understand even more about smile analysis, that drawing lines actually isn't enough. Because, you know, the reality, and there was some nice papers that we're going to share, all the papers, is that right, Howie, with everyone?
Yeah, we are. If Jonathan's got them, we're going to share the
Okay,
papers.
I'll
We'll
share them as well, but we'll share. There was a beautiful paper that actually went one stage further to say that actually the reality is that we can't analyze people's faces just with horizontal and vertical lines. That, you know, there are certain symmetries, asymmetries that we're going to find in everyone's face. And so that's where we talked about the facial flow, and I'm not going to go into that, but there's a beautiful paper that we'll share from Bruno Pereira, Eduardo Mann, and Kyle and Christian. And it just allows us to see facial asymmetries and to deal with them in a constructive way. That's all we're saying, is that, you know, we don't want to just create smiles that are even just mathematical and perfect, because that doesn't exist either. So, you know, these things are evolving all the time, and things like, you know, that we're working with, you know, things like artificial intelligence are incredible in helping us direct that we get the teeth in the most perfect patient for that person, teeth and for that patient in that case. Yeah.
Just a question here. Obviously, this is a brilliant landmark paper. I think if you could just give a brief analysis of what the facial flow does and why the facial flow makes a difference, and how does it actually change your planning?
Yeah, so basically, if we look at someone's face, we'll find that actually using just bipupillary lines is not possible. I think that it's only in 16% of cases that they're actually parallel to the natural head position. So this is why we start to incorporate other points in the face and look towards actually what is happening with each individual, because often we'll find that the flow of the face, in other words, if we draw a line from glabella to the tip of the nose to the philtrum in the chin, we'll find that the line that's created is actually moving in one direction. And so the key element is that we then have to design the restorations or the smile that it moves with that orientation, not against it. Because a lot of cases, before I understood this concept, you know, we would have a ever so slight cant, or there'd be something that was moving against the flow. And, you know, it looks terrible, but it can be tiny, but you look at it and you can't understand why it looks so terrible until you understand about these sorts of things. So what we're saying is that facial analysis has moved so far, you know, but we were still doing these things back in 2013. And this really changed our concept of how we treated patients. There's no question.
Absolutely.
You know, and I think it maybe even started before this case. But yeah, let's go on a little bit. So we're going to, first of all, analyze, but now we can, once we've analyzed the face as a whole, we can start to look a little bit more specifically at the kind of dentolabial relationship. And really what we start to do is we start with the incisal edge position, because that's going to determine the smile curve. And yeah, I think one of the most powerful things in a good treatment is being able to address the smile curve. The moment we don't fix the smile curve, or we don't understand the smile curve in the case, it's going to be a failure. And from there, from the incisal edge and the smile curve, we obviously go to tooth proportion. And from the tooth proportion, that will tell us, and certainly in a case like this, where the new soft tissue margins of these teeth in the anterior zone need to be. So we're not thinking from the soft tissue down to the incisal edge, it's the reverse. And that's the key in the planning of this case. So creating the correct smile curve based on the new incisal edge position, creating correct tooth proportions, which will allow us then to determine where that soft tissue needs to be, and not the other way around. Have we lost you there, Howie?
No, I'm here.
I think we've
I want to put you in the spotlight.
Yeah, no, it's fine. So what I was saying, and I'm going to move on from there, is that it's really an important process. So from the analysis, we go into DSD. And I think the key concept of whether you use DSD or there are a bunch of other tools out there, is that we need to understand about the demands of the patient's face before we start drawing lines. So, you know, facial analysis is the beginning, and then we start to draw the lines of where things need to go. So here we were using Keynote, you know, now there's really some cool ways of doing it. So if we go on to the next slide, we can see that we've got the smile curve. The 12 o'clock position is a really important analysis, because remember that when we're doing all these frontal decision-making processes on a frontal, we have no idea about the buccal volume or the occlusal elements. So these are just frontal pictures that we're looking at here, which are super important. And we'll come back to the 12 o'clock when we see the mock-up. Because again, I think in any case like this, you know, mock-up is a key element of the treatment planning. You know, mock-up is something that allows, again, all of us to understand the challenges of the treatment, and it allows the patient to visualize the end outcome so that we're all on the same page. So if we go to the next slide. So what we've done now from the facial analysis, we've determined where the exact incisal edge position needs to be. We can from there look at the new smile curve, and we can also determine where the new gingival margins need to be and whether this is going to be a problem or not. And of course, for the 1-1, we can see that that's an issue, because obviously of the ankylosis, and that tooth couldn't be moved back down all the way down to where the eventual orthodontics would have ended up at. And also it's interesting because, again, you know, if we treat the tooth and not the face, you would have seen from the DSD that we talked about a treatment plan that involved what, 3 teeth, yeah?
Yeah.
And so from the DSD, what I'm seeing is actually I need to treat 4 teeth. Yes, you know, that the 2-2 needs treatment, and it's a minor amount of treatment. But if I don't treat that tooth, it needs slight lengthening. it's going to be a failure from an aesthetic point of view. So this is so much information from the restorative point that I'm also going to be handing to the surgical team to say, okay, now here's your challenge. This is where I want you to work to, you know, and you have now the guide in order to make sure that this happens, so that we can then deliver the case to the patient. Does that make sense?
I think, Mark, this also kind of ties together what we said in the treatment plan slide when we first started, the fact that we have our second treatment plan discussion, and it's only now really that you can start giving the costing, because only once you've done the analysis aesthetically can you start to work out what the patient actually is looking for.
Yeah, 100%. So let's carry on there. So yeah, that's just looking at angles and shapes of teeth and papilla and what's going to be missing, what's not going to be missing. And you know, I think now we can start to communicate to everyone, because, you know, don't forget that once we've done the planning and we've done a mock-up, you know, everything certainly today needs to be guided, you know, the prostho and the surgery. So, you know, we need to now give this information to the laboratory. So, you know, we're not going to just tell them to lengthen the teeth. We need to tell everyone how much we need to lengthen the teeth. We need to tell the surgical team where we need the soft tissue to go, from a measurement point of view, not just I need it longer or I need it shorter. So, you know, now we're being much more specific, and this is the key. You know, again, it's meticulous planning. And so
it's a great communication tool for us.
Yeah, and I look at this and I'm like, wow, that's how we used to do it, but it worked. You know, that was the beginning. You know, and really, you know, case after case, I got more enthusiastic because I realized the value of going through this process. You know, and a lot of people look at this just as an unnecessary step in the treatment. But for us, it's not unnecessary. It's you know, it's mandatory. Yeah, it's mandatory. So yeah, lip line. I think that what we've also understood about it, and you and I have heard it. We've spoken about there is no such a thing as a low lip line. You know, we have to treat, in my opinion, every patient that they have a high lip line. You know, I think that's the goal. You know, that we're not going to say, okay, we're not going to bother because you can't see it. Because again, that same team, Bruno Pereira and Eduardo, wrote a paper on comparing, you know, the use of static versus dynamic images to make decisions based on soft tissue. And I'll just very quickly give you the stats, because on the static smile, what they found is that 90% of women showed soft tissue, showed gingiva, and 74% of men. And in the dynamic smile, okay, which we don't normally see, just to remind ourselves, because, you know, that's not going to be evident when we ask a patient to smile in front of a camera in a dental surgery. And in a dynamic smile, what was interesting, they found 100% of women and 95% of men. So look at the jump. Wow. Yeah, and we based all our gummy smile. Yeah.
That publication we'll have in the link as well. We'll put that in the link as well for them to download.
In other words, basically treat the problem. Don't you know, fall behind the lip, and don't pretend that those issues are not relevant to the patient. That's my feeling.
Mark, I think one other point, you know, people often talk about lower lip line as a get out of jail free card. You know, you can kind of do what you like, but a low lip line doesn't mean the patient doesn't lift their lip and look in the mirror.
Yeah.
And if the gingival line's not right, if the soft tissue profile is not right, if the tooth, if anything's wrong at the transition zone, despite the fact that you've got a low lip line, they come back, because it's really got to do more with the patient's psychological makeup, how they perceive their teeth rather than what they can see. And I think it's a very important thing that we get out of our mindsets thinking that a low lip line, we can do anything, it's not a problem. Because you hear that in a lot of lectures around the world. It's like, oh, low lip line, so it's not really an issue. It can be an issue. And if you think you're going to get out of jail, that's the one that's going to come and bite you and land you up in a court of law, because you haven't given the patient the problems associated with that.
Yeah, 100%.
All right, so take us through the mock-up here.
Yeah, so here we did the mock-up for the patient. Obviously, that DSD was sent to the lab. In those days, we'd used wax and wax-ups. Obviously, today that's changed completely. We work completely digitally. which is more accurate, more predictable, more streamlined. But yeah, I mean, what we've done in this picture is that we've corrected the smile line. And again, you know, for me, looking at a picture, you know, I used to be critical. I used to look at models and say, I can't judge this case because I need to see a photo. Now I look at a photo and say, I can't judge this case because I need to see more photos. Yeah, I need to see more photos. And so, yeah, that's how we developed. And so, you know, that what we're looking at is the dentolabial interaction. In other words, how does the teeth, how does the new shape of the teeth and new incisal edge and form of these teeth, and bear in mind we've treated 4 teeth here in the mock-up, blend or integrate with the lips and the face. And so, you know, again, if I think we go to the next slide, if that's possible. Yeah, what we see is now I can start to make a better decision, because this is how and that's why we take videos of the mock-ups, because then we can see the dynamic element to the smile. And now we can start to evaluate not just one photograph and make a decision that that's right or wrong. But what I'm seeing now is the correction of the smile curve. And what I'm seeing is that the white aesthetics looks good. However, I can't judge the pink aesthetics. Why? Because actually I can't get him to get to that dynamic smile. That's the problem. And so, you know, this is why, this is why don't fall behind this, because if we go to the next slide, and if we stuck just to this plan, what do we see is we see a lot of problems in the pink zone. You know, that smile looked amazing, but now I've given him teeth that are incorrect proportions. And so we have to start to manage these challenges, that we keep teeth to the right proportion, because this is super important, and that we don't move the incisal edge, because what often I see, if implants are in the wrong place, it's either a combination of 2 things. Either the tooth proportion has to change, okay, to accommodate the incorrect soft tissue position, so we get long crowns, or they say, okay, we're going to give the tooth the correct tooth proportion, in which case we're going to shorten the incisal edge and we get a reverse curve, smile curve. And so here we have to be very specific that we want to keep to these rigid guidelines of keeping the incisal edge in the right place and keeping the tooth proportion correct. So yeah, that's my input. And then we now look at the challenges of the case, you know, and see, you know, yes, I can do it. No, I can't. If we can't, then maybe this becomes a pink porcelain case, or a pink case that we have to supplement, and makes different treatment planning decisions. But yeah, look at the buccal volume. From the frontal view, you have no idea about buccal issues. And so the 12 o'clock, it's important to think about planning in a 3-dimensional way. And that's why I love the digital world, because everything is 3D. And so, you know, but this was 7 years ago, and it was still working really well for us. But, you know, it's progressed, you know, it's unrecognizable. But, you know, this was still the way forward, and we were doing this, as I say, so many years ago, and it worked really well. And you know, hopefully everyone agrees when they see the outcome where in a few sessions time. But yeah, so that's kind of my element of making sure that this always has to happen, that we have to think about the face, you know, to treat the face and not the teeth. That we are dentists, I understand that, and maybe it's a big flaw in dental education, that we weren't taught to think about faces. We were taught to think too much about just fixing teeth.
Yeah. All right. Thanks, Mark. That's great. And I think just to summarize, and we're going to end off here because we're about to get ready for surgery. But I think in summary, there's a couple of things we need to look at. Number one, tooth positions are now worked out and confirmed. The patient has been given the mock-up, and they now already understand what they're going to get. The technician knows what is expected of them in tooth position. The tooth positions are now used from face to mouth to tooth to give us our implant position. So whatever we decide with the implant placement, we now know exactly where that's going to be. The tooth positions also now are used in a provisional form. So whatever provisionals we work out, and we're going to talk about that in the next session, we know exactly what shape they're going to take. And by giving the patient that provisional at the next phase, we also allow them to walk around during the healing phase to assess, to see whether that's something that they can live with and is this something that they're happy with? So it's not like you put the crowns in and then the patient looks in and it's like, yeah, I'm not sure. Or they go home to their wives or husbands or parents, and then a week later they're back and like, my wife doesn't like the color, my husband doesn't like the shape, or, you know what I mean? How often does that happen in the past, Mark? I mean, that happened all the time. And this is the whole concept of aesthetic diagnosis, emotional dentistry, getting all of this. So we've got all of that nailed even before we get to the final product. And I think that's the summary of what you've been trying to say and the key to everything that we've been doing. We are now ready for surgery, and we're going to continue into the next session with us, which will be probably within the next 3 to 4 days. We'll be advertising the time. But again, I want to thank everybody for listening. Mark, thank you for doing everything. Jonathan, thank you for hosting everything and for giving all the information. Join us on our Facebook page. Join us on our Instagram page. Come and see our website. And more importantly now, we can join us for the next time to discuss the actual surgical treatment and how we did that. So what we're going to do now, we're not going to stop. We're going to now take some questions, and I'm going to ask Jonathan, who's been correlating the questions and collecting the questions for us, to throw some questions at us, and let's see if we can answer as many as we can.
All right. Yeah, some of the questions from the Facebook viewers. Let's start with the first one. Someone asked, how about IDR? Martin Stellarosa's immediate dental-alveolar restoration technique. Howard, do you want to comment if that was a treatment option for you?
Yeah, IDR is a phenomenal treatment option, and I think it's a great treatment for Carlos de Rosa. I've done many cases, but I tend to treat only buccal. I think the extent, there's two things here for me. Number one, how much tuberosity can you, so just let me explain what IDR is. The immediate dental alveolar reconstruction is a technique designed by a brilliant Brazilian prosthodontist, funnily enough, Carlos de Rosa. And the technique basically involves taking of tuberosity bone, because it's so highly vascular and has such highly cellular bone that it turns over very, very quickly. And what he does is, without raising a flap, he extracts the tooth, he puts the implant, he puts the bone in, and in his case, he does three-dimensionally, both buccal and palatal. It's not something I personally do, buccal and palatal. So it's not something that would have been in my armamentarium. Is it an option? Yes, it is. But the problem is you need to put the implant in straight away. And I don't think that in his case, there was enough apical bone to get us the primary stability that one needed. So there's that possibility. The second thing is that how do you then manage teeth next door? And the risk of infection, not knowing that the apicectomies that you do is going to be successful, I think took that out of the drawer. Would I use that as a first option? Yes, if I had healthy teeth on either side, if I had buccal bone and I had good tuberosity, without a doubt that would have been a first choice for me, but not in this case. I don't think that was the right option.
All right, I think this question can be fielded by Mark. A couple of slides ago, you had a 12 o'clock view in your SMILE analysis, and the title to your slide was buccal view, or assessing the buccal corridor. Could you just comment on how you assess the buccal view or the buccal corridor, your buccal space?
Yeah. So basically, we're not looking to see that we fill anything. We're looking to see that we have symmetry on the buccal segments. So you could see on one side, it was further towards the labial than the other. So it's not assessing. To assess the actual buccal volume, you need to then go to the next view, which would have been a complete occlusal view. So this is really looking at symmetry in the labial area. That's really what we're looking at. So it's a buccal volume, but it's symmetrical buccal volume, that we don't lose symmetry in the case.
All right, and I think our last question could be for either of you. Someone asked, I thought a cantilever as a treatment option is bad. Wherever you place it, what are the advantages behind favoring a distal cantilever over an anterior or mesial cantilever, as you mentioned?
Mark, give it a start.
Yeah, listen, in the posterior, obviously the disadvantages, and we're not really, this was an anterior case, is managing the load. I think that's the one of the issues, is that we now have a load that's not centered through either the tooth or the implant. And so from a kind of an occlusal point of view, this is not ideal. So, you know, that would be my concern, and it's much more difficult to manage that in the posterior. In the anterior, it's a little bit easier to manage the occlusal elements if we have guidance on different teeth, that we can take that load off that cantilever. So that's a little bit easier. So I'm not a big fan of cantilevers in the back of the mouth at all. In fact, I would say it goes too far as to say, for me, that's not something that I would do. But in the front, because you can manage the occlusion a little bit better and take the guidance off that particular tooth, it's a possibility for sure. And I've done them successfully.
I think I would totally agree. I think there's one aspect to it that we need to look at as well. Certainly anterior, definitely. I think cantilevers, where I'm going to, one has to look, number one, at the bite. You know, if I've got a severe bruxa and I need to do some implants in the anterior zone and the patient's a class 3 bruxa, I'm going to stay well away from any cantilever. I'm rather going to put more implants in, splint the implants, etc., to try and maintain biological integration and stability in that area. But in a case, as Mark said, where you can control the bite, and controlling the bite is much easier on a mesial cantilever, number one. And number two, it's much easier when you're doing it for a lateral. So if I can, so that would, I suppose, mean a distal cantilever as well if you're doing the central. But any tooth that you can control the bite on clearly, where you can actually either reduce the bite slightly on that tooth and even keep it out of the bite and put all the force on the implant rather than on the cantilever, I would be happy to do that in the anterior zone. Remember as well that sometimes we know from the interproximal height of bone studies from Salama and Team Atlanta that pontics give us much better papilla when you've got an implant adjacent to pontic than another implant or anything else. So if we do have a pontic site, then certainly we're having an implant, 2 implants next to each other, as Mark said, is not a great option. So where we have 2 implants and socket shields or partial extraction therapies are not possible, then a pontic, cantilever pontic, a cantilever bridge would be actually a first option for me. I don't know if you agree with that, Mark.
Yeah, listen, I think that's an option. The other thing I just would like to add very quickly before it goes on too far is that remember that occlusion, you know, is dynamic, and so occlusion changes. So again, this is the importance of maintenance. So, you know, we might do an occlusal adjustment to make sure today there's no force on that cantilever. But let me tell you, in a year's time, that might not be the case. And so this is the importance of getting our patients back in. And at some point, I can tell you that what will happen is that there will inevitably be loads that we didn't anticipate or we didn't want on that cantilever. So, you know, beware of them and monitor them and watch them closely, because as I say, the occlusion will change over time. That's what happens to all of us.
Sometimes a provisional bridge on a cantilever for 6 months to a year is not a bad option before you go to final.
Yeah.
Okay, John.
Okay, I think that's the end of our questions. We'll be wrapping up. Howard, do you want to have some final words?
Yeah, cool. I just thank you very much, everybody, again for looking. We look forward to seeing you again in the second part. We will discuss the surgical aspects of the treatment, and I'll take you through how we did it, what we did. And then the final aspect we'll have the most fun, and that's where we'll talk about the complications and how we manage the complications, and then also share with you the publications that we got out of those complications and how we handled them. So thanks once again, Mark, Jonathan, Laura in the background. Thanks very much, everybody. Have a good evening. Enjoy, stay safe, and stay corona free.
Right. Bye-bye.
Cheers out.